All right, this lecture is going to pick up where the other one left off. So, adventitious lung sounds in chapter 21. Crackles were formerly called rails. They're commonly heard in patients with fluid in the lungs. Gurgles are low-pitched wheezes. They were formerly called rhonchi, typically clear with coughing. Stertor are snoring sounds produced when patients are unable to cough up secretions from the trachea or bronchi. Stridor is that characteristic of an upper airway obstruction occurring with or laryngitis. A wheeze can be found in asthma or emphysema. That's going to be that musical type of sound that you hear. When we measure oxygen saturation, we use a pulse oximeter. Oxygen saturation can be spot checked or continuously monitored. The device will measure the oxygen saturation by determining the percentage of hemoglobin that is bound with oxygen. A sensor or probe is attached to an area of the patient, which infrared light can reach the capillary bed. A finger or toe clip-on probe is most commonly used, but adhesive sensors can be applied to the nose or the forehead. A clip-on probe is also available for use on an earlobe or an infant's foot. The oxygen saturation should be documented with the other vital signs. When we measure blood pressure, we obtain information about the effectiveness of cardiac contractions, the adequacy of blood and volume in the system, and the presence of any obstruction or interference of blood flow to the vessels. The average blood pressure in a healthy young adult is less than 120/80. 120 is the systolic pressure, 80 is the diastolic, and the difference between the two, which in this case would be 40, is the pulse pressure. Take a look at table 21.5 on page 370, which has some classifications of blood pressure. And you can see normal blood pressure ranging to elevated, stage 1, stage 2 hypertension, and then hypertensive crisis. Many factors influence our blood pressure. Infants will generally have a very low blood pressure, and the blood pressure will gradually and steadily increase with age. It's important to know each patient's usual range of pressure, and some factors may be influencing it, rather than just making judgments on only one measurement. Ask your patients whether or not they have a high or low blood pressure, or consult the medical record for other baseline readings that have been recorded. A noisy environment and crowded room conditions can cause a temporary elevation of blood pressure. Anxiety, fear, and stress will elevate the blood pressure. Take a person's blood pressure in a quiet and relaxed environment. The patient should sit in a chair with the feet flat on the floor and rest for at least 5 minutes before the blood pressure measure is taken. We measure blood pressure with a sphygmomanometer, which is the manual blood pressure cuff, or just the actual cuff. We know from lecture, we discussed that the best way to assess the blood pressure is through an arterial catheter put in through an artery. And we call that an A line within the hospital. But when we don't have that, because it is quite invasive, it's not necessary for everybody, we're going to use our sphygmomanometer to take a manual blood pressure or use the electronic vital sign monitors. The electronic vital sign monitors don't require the use of a stethoscope, but they are more expensive than the traditional manual blood pressure cuff. The cuff needs to be the correct size in order to obtain a blood pressure reading. A narrow cuff should be used for small children and a wider cuff for muscular or obese people. Using the wrong size cuff produces errors as great as 25 points. The proper width should be 21% larger than the diameter of the arm, and the inflatable bladder should go around at least 3/4 of the arm. A standard acoustic stethoscope with wide tubing, soft ear tips, and a diaphragm head is net satisfactory for taking vital signs. On page 371, you can see the Korkatov sounds as well as the different phases that they go through, and we all listened to those in clinical as we successfully checked manual blood pressures last week. It's important to continue to listen until the cuff is completely deflated so that you don't miss an oscillatory gap for the last Korkatov sound. This is especially important in our elderly population because many older adults with hypertension have an oscillatory gap in their Korkatov sounds. If you simply pumped up the cuff until you didn't hear any more sounds and then let the air out, you might miss that upper point for systolic blood pressure. So it's important to continue to listen until the cuff is completely deflated. When you can't determine your blood pressure by auscultation, you can use the palpation method to estimate your systolic pressure. Diastolic pressure cannot be measured this way. To do this, the appropriate place, and simultaneously you would place your fingers on the radial artery. You pump up the blood pressure cuff until you can no longer feel the pulsation of the radial artery. The number that you pump up to is generally what your systolic pressure is running about. In the ER, sometimes we'll be unable to get blood pressures on patients, and sometimes you can still feel a radial pulse on them. When you can feel a radial pulse on them, you would say that their blood pressure is help. And we know that at least they have some type of blood pressure at that time, which is better than no blood pressure. So that might be a term that you could hear as well when discussing blood pressures. Pressure consistently above 130 systolic or 80 diastolic is considered hypertension. Hypertension is more common in African Americans, who typically get it earlier and more frequently than our Caucasian and Hispanic American population. Recall from structure and function are non-modifiable and modifiable risk factors when we discuss hypertension. Prolonged hypertension can cause permanent damage to the brain, kidneys, heart, and the retinas in the eyes. Prolonged hypertension is a cause of many strokes, and that's one of the reasons why we call it the silent killer. Orthostatic hypotension is a drop in blood pressure when arising to a standing position, or just when changing positions, lying down to sitting up to standing. Because the elasticity in our elderly population decreases in their blood vessels as they age, it predisposes them to this type of condition. They will have pooling of the blood in lower extremities when they stand, and that could cause them to experience dizziness. Our elderly population is at risk for falls, especially at risk for falls due to this type of condition, the orthostatic hypotension. Placing elastic stockings on the lower extremities can lessen the problem. You should also allow this patient to sit on the edge of the bed and dangle for 1 minute before they stand up. Doing so will allow their blood pressure and pulse to equalize, and therefore they will be less of a fall risk when you get them up. A systolic blood pressure of 30 or higher and a diastolic pressure of 80 or higher is regarded as outside of the abnormal range and considered hypertension. Blood pressure that is consistently outside of the normal range should be reported to the charge nurse or the primary care doctor only if the patient does not have a history of hypertension. Promoting home blood pressure monitoring is very important, and if a patient has been diagnosed with hypertension, you should encourage them to monitor their blood pressure at home. Have them get a blood pressure cuff to use it at the house, and then make sure they know how to use it properly. They should track their blood pressure twice a day and then record it in a small journal. Then, their primary care doctor, rather than having one reading to look off of, they'll have an entire list of readings to go off of, which will make them better prepared to formulate a really good care plan for you. Hypotension is low blood pressure, and sometimes hypotension can occur with symptoms of shock or circulatory collapse. This is a dangerous condition that can rapidly progress to death unless treated. Shock can be caused by hemorrhage, vomiting, burns, and myocardial infarction, among other conditions. Signs and symptoms of shock include a decrease in blood pressure, an increase in pulse rate, cold, clammy skin, dizziness, blurred vision, and apprehension. Whenever taking a patient's blood pressure, as we discussed in lecture, you always want to assess whether there are any contraindications to taking the blood pressure on either arm. Some contraindications would include the patient having a previous mastectomy, a serious injury, or a lymph node dissection, or if they have an IV line or dialysis shunt in the arm. In these types of situations, you would use the other unaffected arm. If both arms are affected, you could use the legs. So postural or orthostatic hypotension is a drop in blood pressure that occurs with a change from supine to standing, from sitting to standing position. Sometimes this can occur due to drug therapy, a neurologic problem, or dehydration. Blood pressure should be taken in both sitting and standing positions for these patients. A drop of 15 to 20 millimeters or points from the patient's baseline blood pressure, combined with any symptoms such as faintness, blurred vision, dizziness, or syncope, would signify orthostatic hypotension. Orthostatic hypotension is caused by a failure of vasomotor compensatory mechanisms in response to position changes or baroreceptor reflex impairment. Blood pressure can often be assessed to determine how a patient is responding to a procedure or a drug treatment. and it's an important measurement in evaluating any patients with cardiovascular disease or monitoring with patients in shock. The Joint Commission has identified pain as the fifth vital sign, and it's important to assess it when you assess your other vital signs. The assessment of pain needs to include the pain location, intensity, character, frequency, and duration. Always use your PQRST mnemonic that we practiced in the lab. Always follow up on your pain assessment findings and treatment plan according to your agency policy. If a patient tells you that their butt is hurting and you put a pillow underneath them to turn them onto their side, relieve that pressure, you need to go back in 30 minutes and reassess whether your intervention has been effective in reducing that patient's pain. When you give a pain medication, especially within our BayCare system, a task will ahead and go back and reassess that patient's pain level. You will also be expected to go in and chart your reassessment of their pain assessment. So you need to go back and chart their either decreased or same pain level. Hopefully we're going to see a decrease in that. Remember that pain will always make your vital signs go up. So pain is going to increase your heart rate, your respiratory rate, your blood pressure. And then due to all those things increasing, you could even see an increase in your temperature due to an elevation of the metabolic rate. Within the healthcare system and within our hospital system, we use lightweight, portable, automated units to measure blood pressure and heart rate simultaneously. These measurements can be obtained in 21 to 45 seconds. You can also program these machines to take your vital signs at specific intervals, like every 30 minutes, every hour, every 4 hours. The vital signs are displayed digitally and can be retrieved using the unit's stored data capability. If a blood pressure reading is considerably different from the patient's baseline, always go back and check with a manual blood pressure cuff. When documenting vital signs, carry a small pad and pen around with you to write the vital signs down as soon as the measurements are obtained. If you're using computer entry, enter your vital signs before you go to your next patient. With any unusual or abnormal findings, you may want to include those vital signs in your nurse's notes due to their related to the patient's condition. In the electronic health record, vital signs need to be documented within the correct screen on the computer for every patient. When vital signs are outside the expected norms or reflect a gradual trend or have changed significantly compared to the previous vital signs, nursing actions may be indicated. These nursing actions can be independent of the doctor's orders or dependent based on the written orders that the doctor has provided. After notification of the doctor and implementation of these nursing actions, monitor the effectiveness of your actions by measuring vital signs repeatedly until they return to normal limits. When vital signs merit notification of the doctor, always make a narrative entry in the patient's medical record. The narrative entry should include the time at which the vital signs were measured, any subjective and objective observations, the actions implemented, and the result of those actions. Whenever contacting a primary care doctor, physician, or provider, always document the name of the person that you spoke to. You want to document the name of the person, the time that you spoke to them, as well as any contributing vital signs. So for example, if I called the patient's admitting doctor because my ER patient is about to go up to the floor, but they have a pressure of 200 over 100. Well, I know that my floor nurse is not going to be happy about that when she sees, that rolling up to her when she goes and looks in her patient's chart. It's probably going to cause her to call the doctor and ask for something else. To prevent that situation, I can go ahead and do my due diligence as a nurse, call the doctor, let them know the time that I called the physician's name, the patient's blood pressure prior to calling, what the physician told me to do. So let's say they told me to give 0.1 of clonidine PO once now. I would go ahead and chart that exactly as they said it verbatim. Gave it, and then say that I would go back and reassess, or that I would go in and give it, and etc. So using those vital signs to provide evidence to your actions is very helpful whenever documenting. Frequent measuring of vital signs can be ordered for a patient who has had an invasive procedure, who is taking specific cardiac medications, or whose condition is unstable. And I showed you guys the pre-test answers in the previous recording, so you should still have that. So we're going to move on to chapter 22. Assessment is a vitally important nursing function. This is a continuous illness occurs. Although a staff nurse rarely has time to do a thorough physical examination of each patient assigned, a quick, focused assessment or a survey of all body systems can be performed for each patient at the beginning of the shift. So that is the expectation, is that you would complete a focused assessment for each of your patients at the beginning of the shift. Strong assessment skills can quickly identify any new signs and symptoms that would indicate complications of any illness or adverse side effects of medical therapy. A complete physical examination is typically performed on patients who seek primary preventative care every 1 to 5 years, depending on their age and health condition. A nurse will often assist the primary care provider's examination of that patient. When a patient is admitted to the hospital, long-term care facility, home care service, or other agency, an initial assessment is always performed. In addition to the physical examination, you are also expected to obtain historical data concerning the patient's past and present state of health. The health history and psychosocial data will provide pertinent information about the patient to assist you in administering their daily care. To care for the whole patient rather than just tend to the area of problem, exploration. If a mother is worried about the care of her small children at home, her energy is not going to be focused on healing herself, but rather on them. Assess for cultural preferences and health beliefs so that an individualized plan of care can be formulated. Cultural assessment would include asking the patient and family about preferences for food, bathing, and personal care, what they think about and perceive their illness and treatment, and who should be consulted regarding any decision making. Do not just assume that because a patient is a member of a certain ethnic group that they have the same beliefs and practices common to that group. Always ask. If the older adult has difficulty with memory, data can be gathered from a family member or significant other. On page 382 in box 22.2, I highlighted in my textbook some questions to detect potential physical, sexual, or alcohol abuse in the adult. Sometimes these questions can be very intimidating for people to ask, especially when you don't have a lot of practice asking people kind of strange questions like this, questions you wouldn't normally have in a typical conversation. So take a look at those questions there. It can be really helpful to just kind of see matter-of-factly how you would state something. Within the ER, we always have to assess each patient for any type of abuse. And so the question that I will ask a lot is, do you feel safe at home? When our patients are first encountered, we need to observe their behavior and appearance to begin our assessment of their health status. Always be on the alert for any possible signs of abuse that need to be included in the assessment. The assessment will provide a complete picture of the physiologic functioning, and when combined with the health and psychosocial history, it forms a complete database for that individual. The physical assessment can be performed in a variety of settings, like hospitals, health centers, clinics, schools, long-term care facilities, and primary care doctors and nurse practitioners' offices. The assessment of physiologic functioning ranges from a comprehensive, in-depth examination, including all systems of the body, to a brief scanning type of examination confined to a specific body part or system. That would be your focused assessment. In addition to using interviewing and communication skills, information can be obtained by Look for any contours of the body, skin tone and color, any rashes, scars, or lesions, any deformities or extremity weakness, characteristics of movements, and their respirations. Palpation is one way that we can use our sense of touch to obtain a great deal of information about our patients. This technique involves using the hands to feel various parts of the body. Palpation can be used to detect the size, shape, and position of parts of the body, as well as the texture, temperature, and moisture of the skin. Palpation is used to ascertain any muscle spasm or rigidity, any pain, swelling, or a growth, any restriction in movement of a body part, skin temperature, turgor, and edema. Skillful palpation is based on knowing how to use the fingers and hands effectively. The skin is thinner on the back of the hand and more sensitive to any changes in temperature. The pads of the fingers are used to palpate the size, position, and consistency of various structures, like the lymph nodes and breast tissue. The palm of the hand is used to detect vibrations or tremors, and the thumb and index finger are used to check skin turgor, joint position, and the firmness of other muscles and tissues. Deep palpation will depress the skin 4 to 5 centimeters, or 1.5 to 2 inches, and can be done using one or both hands. Whenever palpating, always watch the patient's face for any signs of discomfort and discontinue immediately if pain occurs. Inform the doctor if the patient has severe pain with palpation. Percussion is another assessment technique that involves light, quick tapping on the body surface to produce sounds. It is used primarily over the chest and abdomen to determine the size, location, and density of the organs that lie within. Different sounds are emitted as the examiner moves from one resonant area to a less or more resonant one. The sounds will vary in their intensity, pitch, duration, depending on the presence of the underlying air, fluid, or solid organ. Auscultation is an assessment technique which includes the process of listening with the aid of a stethoscope to the sounds produced by the body. This is particularly valuable in hearing any sounds produced in the heart, lungs, and abdomen. Use your stethoscope to take blood pressure readings, to listen to the lungs, assess heart sounds, and check for the presence of bowel sounds. When listening to the lungs, use the diaphragm of your stethoscope. Heart valves can be best assessed with the bell of the stethoscope placed lightly on the chest wall. To use the stethoscope properly, always place the earpieces in your ears so that they point forward towards your nose. I always place them when they point away from you. The bell piece, which is the smaller piece, is used to detect low-pitched sounds, like abnormal heart sounds made by the valves. When using it, hold it lightly against the skin, because pressing harder can obliterate or eliminate the low-pitched sounds. Olfaction is using your sense of smell. Your nose can be used to identify characteristic smells associated with certain problems. A fruity odor to the breath can indicate diabetic acidosis. Alcohol on the breath can provide a clue to the patient's lethargy or irrationality. A foul or sweet odor coming from under a cast or wound would indicate an infection. A basic nursing function is to weigh and measure your patient. Adult weight is most frequently measured on a standing scale. Weight can also be measured using built-in scales in beds or chairs. The infant should be weighed with one hand. We would use these vertical measuring rods, usually on the scale that the patient is stepping onto, that standing scale, to measure the patient's height. They should not be wearing shoes when the height is measured. That's what your textbook says. Realistically, I tell my patients not to take off their shoes in the ER because you want to think about hygiene as well. The person should stand with their feet together and centered under the rod with their back to the rod and look straight ahead. That is the appropriate positioning or way to instruct your patient to stand when obtaining their height. Infants and children younger than 3 years of age would be measured in the supine position with their legs fully extended. Most measuring devices are marked in inches and centimeters, and fractions of these are used to ensure an exact measurement. Vital signs should be measured at the time of physical examination. blood pressure should be measured on both arms after the patient has been sitting quietly or lying down for about 5 minutes. The blood pressure reading will be more accurate if the patient's feet are flat on the floor and the brachial artery is at the level of the right atrium, so level with the heart, and neither you or the patient should be talking during the procedure. Never take a blood pressure on the same arm containing a dialysis shunt or IV site, or where a mastectomy or lymph node dissection has occurred. If blood pressure is elevated during an office or clinic visit, take the pressure again right before the patient leaves. Many times, patients will be anxious when facing an examination or interview with a primary care doctor. The radial pulse should be assessed, and if it's irregular, the apical pulse needs to be counted for a full minute. In the hospital, a full vital set of vital signs should always be assessed. That means that you shouldn't just be going in and checking the blood pressure and then leaving, or going in and checking the respirations and then leaving. If you're going to do one, do them all. On page 388, we can see the skill for testing visual acuity. The Snellen eye chart is used to test visual acuity. This test is performed by the nurse during a physical examination at an office or clinic, or whenever there's any question or problem with the patient's vision. Sometimes this testing can be done without glasses and then with glasses. Now, if your patient wears glasses, they need to wear glasses while they're doing the Snellen chart. You wouldn't want to have a patient with prescription glasses take their glasses off and then try to, read the chart. They're not going to be able to read. We know they need prescription glasses. Allow them to wear their glasses for the exam, as long as they're not reading glasses. They need to be actual prescription glasses. And then when you chart the results of that exam, you'll have an option to say whether or not a visual aid was used. And you would put yes, either glasses or contact lenses. And the same thing with contact lenses. If your patient has contacts, you would allow them to leave them in for the exam. Again, we know that they need them. They have a prescription for it. They need these things to be able to see. Allow them to use them. And you would just document as such. So if the patient was wearing glasses, you document glasses. If they're wearing contacts, you document contacts. To perform the Snellen test, you position the patient 20 feet from the Snellen chart. Ask the patient to leave on their corrective lenses, except reading glasses, and cover one eye with an opaque card. You can also use your hand if you don't have a card. I make people use their hands in the ER all the time. Instruct the patient to read the chart and read the smallest line in print possible, reading from left to right. Assess the patient's general appearance when looking at the head and neck, including the color and tone of the skin, its condition, the appearance of the eyes, and the condition of the hair. When assessing the chest, heart, and lungs, you need to assess and see that the chest will rise and fall with respiration symmetrically on both sides of the body. This means that the right side of the chest should rise at the same time and at the same height as the left side of the chest. There should be no difference. When inspecting the spine, always look from the rear and from the side. The spine should be midline with a gentle concave and convex curves when viewed laterally. Inspect the anterior chest to see if there's any noticeable point of maximal impulse or PMI of the heart. Our PMI is located at or close to the fifth intercostal space at the left midclavicular line. You can find the point of maximal impulse and the apical pulse in the same place. S1 is the lub sound and S2 is the dub sound. S1 is loudest at the apex of the heart in the mitral area. S2 is softer at this location and can be heard best over the aortic area. Count the apical pulse for a full minute and always note whether or not it is regular. After you master basic heart sounds, you can begin to practice listening to valve sounds with the bell of your stethoscope placed very lightly on the skin. It does take considerable practice to hear all but the loudest heart murmurs and to determine the type as well as which valve it's coming from. Lung sounds should be auscultated using the diaphragm of your stethoscope. The sounds will vary in pitch and duration depending on the area you're auscultating. Sounds over the trachea will sound loud and coarse. These are known as bronchial breath sounds. Bronchovesicular sounds are heard over the central chest and back. Typically, they are equal in length during inspiration and expiration and Vesicular sounds are soft, rustling sounds heard in the periphery of the lung fields. Generally, these sounds are going to be best heard over the back, more towards the base of the lungs. They are longer on inspiration than expiration, and there is no pause between them. When you auscultate the lungs, you need to do so in a systematic manner, according to a set pattern. I told you guys in lecture how when you auscultate the lungs, I like for you to listen on one side and then listen on the other. Go down, listen to the next spot, then listen on the other. When you listen to the lungs, you need to do so in a symmetric, systematic fashion. If you listen on one spot, you need to listen on the other side. Then you go down, then you listen to the next spot. You can see a really good visual of what I'm talking about on page 390. They show you with numbers 1, 2, 3, 4, 5, and then they show you again on the back 1 to 9. Now notice how you have more listening sites on the back than you do on the front of the chest. That is not a mistake, that is correct. Reason being is because, as you can see based on the anatomy that they're showing in these pictures, you don't have very many structures over the back of the lungs. The base of the lungs, when listening to them from the back of the patient, you don't really have a ton of bones or structures that are in the way that's going to impede you being able to hear those sounds. Therefore, they will sound so much better, and you'll really get a lot more information. That's why it's so important that we don't eliminate the step of listening to our patients' backs. If you listen to the front, you need to listen to the back. Look at all the assessment sites that you can listen to on the back compared to on the front. You really get a much better picture of their respiratory status when you listen to both sides. So important not to just eliminate that back side. Always listen to front and back. And I will take points off you guys when we check off on these skills in the Sims lab if you do not do a comparison of left and right when you assess the lungs, because I am very particular about that. When assessing the skin and extremities, before we go to the skin, when you are performing auscultation for the lungs, you need to perform auscultation on the initial assessment and then again once per shift on all patients who are on bed rest, who have a respiratory problem, or who are at risk for a respiratory problem. This is going to be because our patients who are on bed rest, who have a respiratory problem, or who are at risk for a respiratory problem, they're at a higher likelihood of developing any type of complications or illness. So we want to be on top of that and anticipate that before it happens. When assessing the skin and extremities, we look for any types of rashes or lesions, and the assessment will frequently include the Braden scale for predicting pressure sore risk. And we saw the Braden scale, I believe, in chapter 18. Maybe it was.
Right. Yeah, hold on just a second. Let me go back to where I was.
So if you want to go back and review the Braden scale.
Okay, all right. So what can we answer for you?
The Braden scale is on page 304 in your textbook. When assessing the skin, there should be no flaking or excessive dryness. Ask the patient about any changes in moles or other lesions. Check the nails for any discoloration or abnormal appearance. Abnormally shaped fingertips can sometimes indicate a cardiopulmonary problem. Check the patient's capillary refill time by observing the color under the nail bed and then compressing the nail bed with the thumbnail of the distal end with a capped pen. Release the pressure and then note how quickly the color returns to the nail bed. If the color returns slowly, check it again and count the seconds, 1 1000, 2 1000, 3 1000, to estimate the number of seconds it will take for the color to return. A normal capillary refill time is less than 3 seconds. When assessing your pulses, always compare your peripheral pulses bilaterally. That means that it's important to check the radial pulse on the right side and then check it again on the left side. For any generalized edema by checking for any weight gain over a short period of time.
that allows
To check for any dependent edema, press the fingers into the tissue over the tibia just above the ankle. If any indentation remains there, it is considered pitting edema. To describe edema, you can use terms such as taut, tight, puffy, indented, or pitting. If any pitting is present, it needs to be classified according to its depth.
If you were just going straight to a bachelor's, program.
When assessing the skin, we also need to inquire about any abnormal sensations in the skin, like any tingling or twitching, that would need to be further explored. When looking at the abdomen, we assess bowel sounds on admission and then once per shift for all of our patients. Bowel sounds are wave-like and gurgles that occur about 5 to 30 times a minute. Bowel sounds will be particularly active after eating, between meals, and normally it's normal to hear only a few sounds. Bowel sounds could be normoactive, which is normal. They could be hyperactive, which occurs very frequently, and hypoactive if there are long periods of silence. Bowel sounds are considered absent if no sound is heard for 2 to 5 minutes in any of the 4 quadrants. And you'll recall the 4 quadrants of the abdomen from structure and function. If no sound is heard when auscultating the bowel sounds, you need to progress through the other quadrants until no sounds are heard, and be sure to listen to each quadrant for a full 2 minutes.
Well, right. Now the Just Baycast standard 3,000, or with this other plan, most of the time you should be able to get 5,250.
After auscultating and percussing the abdomen, you want to gently palpate each quadrant, looking for any areas of tenderness, pain, or abnormal masses. When documenting the findings, note the size of the abdomen to establish a baseline for any future comparison. Whenever assessing the abdomen, we also need to note the shape of the abdomen. If no bowel sounds are heard, you need to listen in all quadrants for 3 minutes each to confirm. So you listen to each quadrant for 3 full minutes to confirm the absence of bowel sounds. When it pertains to the genitalia, anus, and rectum, unless the patient has a specific complaint or problem in those areas, the nurse does not visually assess them. Ask the patient if they have any problems with these areas.
Even that has changed a little bit, actually, kind of a lot. We used to be able to, people just had to kind of meet the minimum.
When we're implementing our assessment, we're going to use the information gathered to analyze and develop a nursing care plan for the patient. Each patient should be assessed at the beginning of the shift or at least shortly thereafter. This should be a quick head-to-toe assessment, which will enable the nurse to establish priorities of care and organize her workday.
As if there was no Baycare affiliation.
Provide patient education about any diagnostic test ordered, the purpose, and explain what the patient can expect to experience when undergoing them. You might be asked to do an initial screening of a patient before they are seen by the examiner. This is typically something that is done like within a triage situation in an ER. Obtain a brief history of any complaints. Measure the patient's vital signs and prepare them for the examination by the doctor. You should explain the examination procedure to the patient and answer any questions that they have. Try to put the patient at ease. Most examinations will begin with the patient in a gown, typically seated at the end of an examination table with a drape over the legs. The primary purpose of draping the patient is to prevent any unnecessary exposure. A patient who feels exposed and embarrassed will be tense, restless, and less likely to cooperate. Proper draping will contribute to the patient's feeling of being cared for and promote their relaxation. Before a pelvic exam, the patient should empty the bladder. If a urine specimen is required,
Right,
it needs to be
exactly,
obtained
exactly
before the
right.
patient
So this is
undresses
gonna
for the
raise the
exam.
bar, but at least the
Prepare the
people who are getting
examination
into
table
the
with a fresh
program
paper
will
cover,
kind of
provide a
know
drape,
going
and
in
provide
that
the
they're
necessary
probably going
equipment
to
needed
do
for the physical
okay.
exam. Explain to the patient how to put the gown on and how to place the drape. A female nurse may be requested to be present in the room whenever a male healthcare provider performs a pelvic or breast exam of a patient. After the patient has been prepped, the examiner will systematically assess each body system.
Any
Pupil response can be tested by shining the light into the first eye, then the other eye, and then watching to see if the pupils constrict. The pupils should constrict when you shine light over them.
It's in the work agreement.
The ears are examined with an otoscope. It is normal for cerumen to be in the ear. If there is excess cerumen, the ear may need to be lavaged. This cannot be done without an order from the physician. Hearing can be tested initially with the Weber test. This is performed by striking a tuning fork and placing it in the middle of the patient's forehead or the skull. After the head and neck and heart have been examined, the patient is then asked to lie down on the examination table. The abdomen would be assessed with the patient in the supine position. At times, you will need to perform special focused examinations, such as a neurologic check, which is a brief form of a neurologic examination. Neurologic checks should be done on any patient at risk of increasing intracranial pressure. A decrease in level of consciousness is an indicator of neurologic deterioration. The pupil size should be measured under normal light conditions. Pupils are normally round and equal in size. To look at some pupil sizes, take a look at the scale on page 400. At the very bottom of the scale under number 2, you're going to see the pupil gauge or pupil sizes. Now, generally, pupils should be about 3 to 4 millimeters. So 3 and 4 is going to be your average. Anything outside of 3 or 4 is going to be abnormal. A flashlight should be used to make the pupils constrict. It's important to use the appropriate flashlight, which is why I require you guys to get pen lights. Having a flashlight like from your phone shined onto your eye, it's just way too bright. It's going to cause a lot of discomfort. The pen lights that they make for medical purposes, they're not super bright. It's not going to make somebody, seriously uncomfortable. It might make a patient a little uncomfortable while you're shining the light in their eye, but generally this is done very quickly and briefly to minimize any discomfort. Both pupils should get smaller when either eye is stimulated by the light, and this is called a consensual reflex. This means that if you stimulate the right eye, if you shine a light in the right eye, it should constrict, and the left pupil should also constrict. Pupils will constrict when looking at a near object and dilate when viewing a far object. We call this accommodation. Normal findings are often documented when considering the eye as the form of perla. Perla means pupils equally round, reactive to light and accommodation. Eye muscles can be tested by checking the extraocular eye movements. Ask your patient to track your finger or an object as it is moved to 6 different positions. The eyes will normally move in a coordinated manner. The Glasgow Coma Scale is used in most hospitals to score the neurologic examination for patients with a decreased level of consciousness. This will provide a baseline in which changes can be evaluated. The Glasgow Coma Scale can be seen on page 401. That is important for you to study. It is very, very commonly used as a just quick, brief, and dirty neuro assessment on a patient. It can also be abbreviated as GCS. When looking at muscle strength and performing a neurologic check, you need to test the muscle extremity strength by having the patient push against your hands with the sole of one foot and then with the other. Then have them cross their middle and index fingers on both hands and have them grasp each set of your fingers with their hand opposite. Check for the degree of strength and also check for equality of strength on both sides.
Tuition assistance. If you drop below that, then you would lose your eligibility for.
So that will conclude the lecture for chapter 23. I'm going to go ahead, chapter 22. That was chapter 22. I'm going to go ahead and share my screen. and show you guys the answers. These are the pre-test answers for Chapter 22.
Yes, it is, but to supplement them,
These are the pre-test answers for Chapter 22.
Rasmussen University, expensive, but they probably have more.
Okay, you guys, this is going to conclude today's recorded lecture over Chapters 21 and 22. Thank you.
So the